Hello everyone, welcome back to our NABH training series. Today we are discussing a very important quality improvement standard, PSQ.5, which focuses on the clinical audit system. Now understand this clearly, clinical audits are one of the strongest tools to improve patient care quality. And NABH assessors pay very close attention to this area because clinical audits show whether doctors and nurses are actually reviewing and improving clinical practices. What is a clinical audit? Let me simplify this concept first. A clinical audit means comparing current clinical practices against predefined standards to identify gaps and improve patient care. It is a structured review process. Very important clarification. Many hospitals confuse clinical audit with research project. These are completely different. Difference between audit or research. Clinical audit checks whether standards are being followed, improves existing processes, focuses on compliance or improvement. Research generates new scientific knowledge, tests new hypotheses. NABH expects improvement-oriented clinical audits, not academic research presentations. Requirement: clinical audits in every department. NABH expects at least one clinical audit per clinical department once in 2 years. Departments covered. This may include medicine, surgery, pediatrics, obstetrics or gynecology, ICU, emergency, NICU, orthopedics. Example, suppose pediatric department conducts audit on antibiotic usage in pneumonia cases. The audit checks whether treatment is according to hospital protocol. Types of clinical audits. NABH allows different types of clinical audits. Disease-based audit, example, diabetes management audit. Cost-based audit, example, rational use of expensive antibiotics. Community-based audit, example, immunization coverage audit. Morbidity, length of stay audit. Example, why patients stay longer than expected. The topic should be relevant to patient care quality, clinical outcomes, hospital priorities. Predefined parameters, very important. Now let's discuss a critical point where many hospitals receive NC. Audit parameters must be predefined. Why important? Because if parameters are not defined beforehand, the audit becomes biased. What must be defined? Before audit starts, hospital must define audit objectives, standards, reference guidelines, checklist, sampling method, data collection method, reporting format. Example, suppose audit topic is surgical antibiotic prophylaxis. Parameters may include correct antibiotic used, timing before surgery, duration after surgery. These should be predefined. Clinical or nursing care both included. One very important expectation, clinical audit must cover both medical care or nursing care. Example, if audit is about pressure ulcer prevention, doctors review risk assessment, nurses review repositioning documentation. NABH assessors often check whether nursing involvement is visible, participation of medical or nursing staff. Now coming to teamwork, doctors and nurses both must participate in clinical audits. Possible participants: clinicians, nursing staff, quality team, administrators. Audit should not become only quality department work. Clinical ownership is very important. Patient or staff anonymity. Now let us discuss confidentiality, a very important ethical requirement. NABH expectation. Patient and staff identity must remain confidential. What does this mean? No patient names in reports. No staff names in presentations. No public blame discussions. Example, instead of writing, Nurse XYZ failed to document medication, you should write, medication documentation incomplete in sampled records. The purpose of audit is system improvement, not blame culture. Documentation of clinical audits. What should be documented? Audit topic, objectives, checklist, data findings, analysis, conclusions, recommendations. Use of audit checklist. NABH recommends using predefined checklists. A well-designed checklist improves consistency and reduces bias. Implementation of remedial measures. Now comes the most important part of the audit cycle. Audit findings must lead to corrective actions. Very common mistake. Many hospitals conduct audit, prepare report, and stop there. That is incomplete. NABH expectation. You must identify gaps, perform root cause analysis, implement corrective actions, monitor improvement. Example, problem identified, high inappropriate antibiotic usage. Root cause, lack of protocol awareness, no antibiotic review system. Corrective action, antibiotic stewardship training, approval policy introduced. Re-audit, Compliance improved from 55% to 90%, closing the audit cycle. This is called closing the audit cycle. Without this, audit is ineffective. Common NC or closure. NC1, clinical audits not conducted. Closure, conduct department-wise audits. Maintain annual audit plan. NC2, audit topic irrelevant. Closure, select clinically significant topics, link with patient outcomes. NC3, parameters not predefined. Closure, develop checklist or standards before audit. NC4, nursing participation absent. Closure, include nursing staff in audit team, document participation. NC5, patient, staff identity disclosed. Closure, remove identifiers, maintain confidentiality policy. NC6, audit findings not documented. Closure, prepare structured audit reports, maintain records properly. NC7, no corrective action after audit. Closure, perform RCA, implement CAPA, conduct re-audit. NC8, audit cycle incomplete. Closure, show measurable improvement after intervention. Final summary, always remember, clinical audit is not fault finding. It is quality improvement through evidence-based review. A good hospital does not fear audits. Instead, it uses audits to improve patient outcomes. In the next video of this NABH training series, we will discuss PSQ.5, management support for patient safety or quality improvement. If you found this session useful, like the video, share with your colleagues, subscribe for more NABH training sessions. This is MediQuality Partners, your trusted NABH guide. Thank you for watching.